Just very quickly, if you do intraoperative radiation therapy, you will have a physicist involved. In virtually every state in the United States, physicists do the calibration, they do the radiation safety, they do the dosimetry, and they keep an eye on you, they keep you safe. They make sure that you're treating the patient with the appropriate amount of dose at the site that you're supposed to be treating it. So that's the role of physicists in radiation therapy, and they will be your partners in making sure that the patients get treated correctly. I'm a clinical medical physicist. I have a group in Northern California. We actually treat at a couple of sites. We treat intraoperative radiation therapy. We use both systems. We use the Zoff system and the Zeiss system at these different sites. So I have a little bit of experience with all of the systems that are out there, and it's true, they are very mobile. At one of our sites, we do throw them onto a truck, take it over to an outpatient radiosurgery center, or an outpatient surgery center, and we do the treatment there. The source itself is actually that small, although it has to be on the end of something that delivers power to it. There's also a couple of little pieces to it that pump water to it. There's a little kangaroo pump and a sterile water bag. And the reason for that is to keep the source cool. How we can treat at 300 microamps, which is much hotter than other sources, is because we're able to cool that source, keep it from blinking out like a hot light bulb. The source itself it's a classic X-ray tube. We boil electrons off of an anode, a cathode, and they smack into an anode, and the X-rays come off, and we get dose. Very quickly, radiation safety. I'm sure all of you are aware of a C-arm and what the C-arm is like in the operating room. These are the types of exposures that you would get from a C-arm system. These are the types of exposures that you would get from a Zoff 50 kV system. Basically, at 1 meter with no shielding of any kind, there's about an 8-fold difference between a C-arm and the Zoff system. So there really isn't that much radiation coming from this. Pretty much any operating room that I've ever surveyed, we didn't have to add any shielding to the walls. Basically, the wallboard was more than enough to shield all of the rooms around. Typically, though, we will have the anesthesiologist or any other essential personnel stay behind a rolling shield so that they can stay in the room. They, for some reason, don't like to leave their patients. What does the source look like? Well, the source distribution pattern, it's a little bit of a bump to it. If you'll notice, it's sort of cherry-shaped. If you rotate this in 3 dimensions, there's a little bit of a dip at the far end of it. That dip actually goes away because this source can move. And so we can shape this source. We can use it to fill in the little dip in the back so we get a perfect dose distribution of exactly the dose that we like to across the surface of the applicator. And those applicators can be any size, as Dr. Franciscotti mentioned. They can be elliptic or spherical. The source itself, it drops off fairly quickly. Now, I'm showing you a slide that we originally looked at when we were working with APBI. As a comparison with iridium, the surface dose with iridium falls off fairly slowly. With any 50 kV source, you're going to be a much hotter dose at the surface and falling off at depth. One of the differences, though, with IORT is that we prescribe to the surface, and what we expect is for the dose to drop off fairly quickly at depth. In comparison to iridium, and many people have said, well, why don't we go ahead, if we're going to do IORT, and we've got an iridium system back home, or the RADONC does, let's use the iridium system and we'll treat with iridium. These were the slides these slides show you that while you're getting the dose to the surface, you're also getting a lot more dose to the heart, to the lung, and the ribs with an iridium system than you would with the lower energy 50 kV system. As I said, you can get these, you can make these balloons, these applicators in any shape you want, simply by changing where the dwell points are, where you put that radiation point, and it fills in the dose very nicely. You can get within 5% of perfect, and pretty much anything from 30 cc's all the way to 130 cc's, basically in about 5 cc increments, or a half a millimeter of difference in the diameter. So you're not limited to full increments or full centimeter increments of diameter of an applicator. You can actually get whatever you need to fit the cavity rather than making the cavity fit your applicator. In order to treat these, the easiest mechanism, well, anybody could go out and create these plans. There are pre-planned atlases where basically you just choose the atlas that fits the size of the balloon that you just filled into the patient. Fairly straightforward. Now, what do those doses look like? Well, this is a pretty common graphic or mechanism for radiation oncologists to understand what kind of dose coverage we've got. What we'll do is we'll take an applicator, in this case CTV, we call it a contour tumor volume, and we apply a 1 centimeter margin around that. That is our planning tumor volume. If I look at that planning tumor volume and I compare it for a couple of different versions of the Zoff system or the original target trial system, basically what it says is that at the surface, I've got a few cc's, just a few % of dose getting actually 20 gray. But when I get down to a centimeter depth, most of the doses most of that 1 centimeter is getting at least 5.5, 6 gray or better than that. So one of the points of this slide, though, is to show you that this dosimetry is virtually identical to the dosimetry that you would see with the original target trial. The original target trial used a system that has a gold source. In other words, those electrons bounce off a little bit of gold and they scatter off X-rays. Well, if anybody remembers all the way back to their freshman physics, depending on what you bounce that electron off of, you're going to get a little bit different of a spectra. And the spectra are different. The difference between the tungsten and a gold source, you can see, are considerably different, especially down below 20 kV. You get all these things we call K edges and L edges. When you go through a centimeter of water, is the yellow trace, or 2 centimeters of water, or tissue, or balloon, or applicator, what you see is that all of the low energy is attenuated. So it basically is gone. It doesn't ever reach the patient. What's reaching the patient in a 4 centimeter balloon after 2 centimeters of filtration are basically the same, effectively in terms of actual energy reaching the patient. So it doesn't really matter which type of material we bounce those electrons off to create X-rays, but really what is getting to the patient and how that dose distribution works. And after this, I'm done, and I will turn it back over to Dr. Francis Scotti. Thank you.